Hello and welcome to the first of this series, Let's Talk Cancer. I'm Andrew Wardley and I'm going to talk about breast cancer first of all. As you're probably aware, breast cancer is the most common cancer in women. These data from UICC in 2020 show the number of cancers in women across the world of all ages. Just under a quarter of those were breast cancer, with a number of just over 2.25 million. In the UK, there are more than 55,000 new cases of breast cancer every year, and it represents 15% of all cancers. Just under 300,000 women and just under 2,000 men were alive with breast cancer diagnosed in the last 10 years. There are 13,000 deaths per year from breast cancer in the UK, and it is the second leading cause of cancer death in women, but it is the single most common cause of death in women aged 40 to 50. Breast cancer increases with age and can be seen in the 20s, but steadily rises to a peak incidence in the age range 65 to 69. The risk factors for breast cancer are those that are not modifiable and those that are modifiable. Age is an important non-modifiable risk factor, with more than half of the cases of breast cancer diagnosed in women over the age of 65. Family history, first degree relative with a breast cancer, doubles the risk of having a breast cancer, and genetic mutations, the two best known of which are BRCA1 and BRCA2. These account for 5 to 10% of all cases. Modifiable risk factors include obesity, physical inactivity, and alcohol consumption. Hormonal factors, prolonged exposure to estrogen, an early onset of periods and a late menopause, and hormone replacement therapy, especially if prolonged after the menopause. There are high-risk populations, and it's important to pay special attention to patients with strong family history or genetic predisposition, as they may benefit from enhanced surveillance or preventative strategies. Diagnosis is generally made through screening. Imaging modalities are mammography, which is the gold standard and is used in screening. Screening typically starts between the age of 40 and 50. Ultrasound is also a useful modality, particularly differentiating cystic from solid masses, and magnetic resonance imaging is reserved for high-risk patients and complex cases. Early clinical signs, the most common being a palpable, painless lump. Nipple discharge can also be a symptom and sign, as can skin changes such as redness or dimpling. Nipple retraction can also be seen. As the cancer increases in stage, the lymph node involvement may become palpable, and for patients with metastatic disease, systemic symptoms such as bone pain, unexplained nausea, and persistent dry cough. Pathology. All cancers need to be diagnosed by pathology. Most breast cancers, 85% of them, are invasive ductal carcinoma of no special type. Invasive lobular carcinoma represents about 10% of cases, and all breast cancers should have estrogen receptor, ER, and HER2 tested. Many also have progesterone receptor tested. The receptors significantly influence the treatment choices as well as the biology and behavior of the cancer. Staging is by tumor size, nodal involvement, and presence or absence of distant metastases. Staging is critical for prognosis and guiding treatment, as well as determining intention of treatment. Estrogen receptors, the picture on the top left shows a very strongly staining estrogen receptor positive cancer. The score is 0 to 8 and comprises the percentage of cells that are staining and the intensity of staining. HER2, or human epidermal growth factor receptor 2, is usually defined as positive or negative, positive being 3+ membrane staining, which is shown on the bottom left. If the staining is less intense, 2+, then in situ hybridization to look for gene amplification is performed. The bottom right picture shows fluorescent in situ hybridization, with the red dots being the HER2 gene copies and the green dots being the centromeres of chromosome 17. No staining, 1+ staining, and 2+ staining in which there is no in situ hybridization amplification represents traditionally HER2 negative breast cancer. There are some subtypes of breast cancer which it is important to know about. Tubular is the first of these. The cancer forms nice structured tubules that look very much like breast ducts. It represents 1–2% of invasive cancers and 9–19% of screen-detected breast cancers. It is usually grade 1, strongly estrogen receptor and progesterone receptor positive and HER2 negative, and it has an excellent prognosis with a 5-year survival of 94% and an overall survival of 88%. The relative risk of this breast cancer causing death compared to an invasive ductal carcinoma of no special type is 58% less, 0.42. Although this is not significant because of numbers, it is consistent with the behaviour of these low-grade cancers. The second is also a low-grade cancer called cribriform cancer. It's sieve-like in appearance under the microscope, represents about 1–3% of all invasive cancers. Again, is usually grade 1, has nodal involvement up to 3 nodes involved in 14–37% of cases, but is generally very strongly estrogen receptor positive and progesterone receptor positive if tested, and HER2 negative. 5-year survival and overall survival are of the order of 100%. Mucinous forming breast cancer is the next subtype. 1–5% of all cases. Again, grade 1. Lymph node involvement in less than 15%. Again, strongly estrogen receptor and progesterone receptor positive and HER2 negative. Prognosis is again excellent with a 5-year survival of 81–90% and 94% in node negative cases. Relative risk of breast cancer death compared to invasive ductal carcinoma of no special type is about 3/4 of the risk. In this series of cases looked at from the SEER database from 1973 to 2002, just under 11,500 cases of pure mucinous carcinoma. Median age at diagnosis was 71. 86% of cases were localized with no lymph node involvement and no distant disease at surgery. 12% had regional nodal involvement and 2% had distant metastatic disease. Like most breast cancers, for those that are not already metastatic, lymph node involvement is the most significant predictor of worse prognosis. The table at the bottom shows the outlook for patients with mucinous carcinoma compared to invasive ductal carcinoma of no specific type at 5, 10, 15 and 20 years. Adenoid cystic carcinoma, it looks like salivary gland carcinoma, is 1 in 1,000 cases, so probably the rarest subtype. It's low grade, grade 1, despite being a basal-like breast cancer. Lymph node involvement is very rare, and it is a triple negative breast cancer with no expression of estrogen receptor, progesterone receptor, and no HER2 expression. Despite this, it has an excellent prognosis with a 5-year survival of 100%. Medullary carcinoma is paradoxical. It is high grade by definition, often triple negative, although a small subset may express hormone receptors. It has a better prognosis compared to high grade triple negative breast cancers. although the prognosis is not as favourable as adenoid cystic carcinoma. The small number of medullary carcinomas that are estrogen receptor positive have a worse prognosis than comparable invasive ductal carcinoma of no specific type. This is because it is resistant to endocrine therapy, and therefore endocrine therapy alone cannot be relied on as a treatment. Micropapillary carcinoma is 1 to 2% of all breast cancers, usually high grade with extensive lymphovascular invasion and a high proliferation rate. It frequently involves the axillary lymph nodes at an early stage and has an increased risk of distant metastatic disease. Indeed, 3/4 of very small micropapillary carcinomas, PT1A, that's up to 5 millimeters in size, are lymph node positive with extranodal spread. Receptors, estrogen receptor and progesterone receptor, are usually positive, often strongly. HER2 is positive in around 60% of cases, and stage-for-stage invasive micropapillary carcinoma has a lower disease-free survival and overall survival than invasive ductal carcinoma, no specific type. It therefore needs more aggressive staging and more aggressive treatment. Basal-like breast cancer represents about 15% of breast cancers. Again, it's usually high grade. It involves lymph nodes less frequently compared to comparable invasive ductal carcinomas, despite its aggressive nature. It isn't the same thing as triple negative breast cancer, although there is considerable overlap, with 70 to 80% of triple negative breast cancers being basal type and around 71% of basal cancers being triple negative. And it's in this group where the BRCA1 mutated breast cancers usually sit. Prognosis is worse compared to similar stage-for-stage subtypes, but it can be very sensitive to chemotherapy, especially with platinum agents. Inflammatory breast cancer is particularly important because it's a clinical diagnosis. It's 1 to 5% of breast cancers and is probably the most aggressive breast cancer that there is. It is always high grade and stage 3 at least. It frequently is estrogen and progesterone receptor negative and HER2 positive, but there can be cases that are estrogen receptor positive and triple negative. Historically, the 5-year survival is 25 to 50%. This has improved with multimodal. You must start with systemic therapy as the first treatment. Treatment options are surgical, radiation treatment and systemic therapies. Surgery is generally reduced over time, and most patients now have a wide local excision or lumpectomy so that they can have breast conservation. Mastectomies still occur with or without reconstruction, and axillary surgery is generally sentinel node biopsy these days, although axillary dissection is sometimes required for staging. Radiation therapy typically follows breast conserving surgery, and it's used to reduce the risk of local recurrence. Systemic therapies are hormone therapy for hormone receptor positive breast cancers, HER2 targeted therapies for HER2 positive breast cancer, chemotherapy for high risk cancers including HER2 positive and triple negative, and immunotherapy is increasingly being used and recognized in triple negative breast cancer. Non-specialist role is to encourage regular screening and educate patients about self-awareness. Screening levels dropped to 64 to 65% during COVID, and this is considerably less than the minimum required of 70% in a screening uptake. So anything you can do to encourage screening uptake would be of great benefit. Promptly referring patients with suspicious findings to a breast specialist or an oncologist. Supportive care, so helping to address the physical and emotional needs of the cancer and its treatment, and managing comorbidities that pre-exist or complicate treatment. Survivorship issues are important for you to get involved in. Help monitor for recurrence and manage late effects of treatment, and to promote healthy lifestyle changes to reduce the risk of recurrence. And this can indeed have an enormous beneficial impact. So the take-home messages are that breast cancer is common, increasingly treatable, and early detection is of great benefit. Multidisciplinary care is essential, including non-specialists, and as a non-specialist, your role in early detection, patient education and survivorship care is invaluable. Stay up to date with screening guidelines and collaborate closely with your local specialists. And I'd like to thank you for listening to this talk, and I am happy to be contacted if there are any particular aspects that you would like me to cover in future talks. I hope you enjoyed this and that you will share it with your colleagues. And if you want to ask more, please contact us at cancerservices.co.uk.